Today on The Balanced Voice, we welcome Dr. Eric Storch, who's a professor and the vice chair of psychiatric and behavioral sciences at Baylor College of Medicine. He's an experienced clinical psychologist with an expertise in the assessment and treatment of children, people with obsessive-compulsive and related disorders, and anxiety disorders. He holds a PhD from Columbia University and is a licensed psychologist. This year, Crime Stoppers has partnered with Dr. Storch and Baylor College of Medicine in a whole new way. Baylor College of Medicine has many studies that help keep kids and adults ranging from 7 to 20 years old to treat anxiety, trauma, depression, OCD, and more mental illnesses. Crime Stoppers is now able to direct and refer students directly to Baylor College of Medicine for screening and treatment. We're thrilled to partner with them so that together we can meet a critical and time-sensitive need in the community. Here's our conversation with Dr. Eric Storch. This is the Balanced Voice podcast.
Welcome to the Balanced Voice podcast. We're so thrilled to be here. We're located in a bunch of different areas today. Jen, you're in Florida. How's Florida going?
Sunny Florida. It's amazing here. Although I'm supposed to be on vacation, but I just worked a human trafficking case. So I don't know if I've been on vacation yet. So I'm ready to come back maybe.
It sounds like you've been working since you got there, but thank God that you're doing what you're doing. I mean, thank God for it.
Thank you.
And Dr. Eric Storch, we're so thrilled to have you. Okay, I'm going to make sure I read this right. We've already gone through your bio, but professor and vice chair of psychiatry and behavioral sciences, Baylor College of Medicine. Welcome. Thank you for being with us.
Oh, man. Thank you so much for having me. This is a delight.
We were introduced to you through a board member who's working with y'all and working with Crime Stoppers. And she said, you've got to meet him. You've just got to meet him. What they're doing at Baylor is so interesting when it comes to the treatment. And I think I was looking at, kids 7 to 20 years old, some of the work that you're doing, the fact that you're using, digital means to work with children, certainly it was very interesting for us because, to be honest, and Jennifer, you're on our board, you see this tips to the Crime Stoppers tip line from students are now having more of a mental health nexus. And so we're just so thrilled to know you, work with you. Can you just share a little bit about what you've been working on and what Baylor College, what you're doing at Baylor College of Medicine?
Yeah. Well, I am. First of all, I mean, it's so great to connect with Crime Stoppers and the work that y'all are doing. I think at Baylor, we're really fortunate to have an incredible kind of institution, college, and my boss, who I hope is listening right now, but it gives us that opportunity to start thinking about some of these mental health concerns. So our work has hit a bunch of different domains, and if you push this button, you could get me going forever. So I'll keep it nice and tight. But one of the areas has really been on how do we improve access to the interventions that we know work for kids who are struggling with behavioral health concerns. Another is how do we build out our workforce to be able to really do these types of treatments. And then some of the other stuff we do is, global mental health. Like how do we take these, therapies or medications that we know work so well, and we're fortunate to have some access to in the U.S., but get them to other countries where they may not have that same access. So that certainly keeps us, pretty busy, happily.
Dr. Storch, do you know Dr. Molly Gordon?
Of course I do. She is amazing.
Amazing. She does everything you just said. I've watched her with that sex trafficking clinic, and it's exactly what you said. Is y'all are working on things here, and then y'all perpetuate it out to the globe. It's phenomenal. Yeah,
well, she is a superstar, and just to be in that same breath, that made my day. I think I'm out right now.
No, we still like you. Please stay.
Please stay. I was saying.
Okay. You convinced me. I'm in.
Before we met Dr. Storch in real life, I listened to a few of your videos and just some of the videos of you talking to younger kids and the mannerisms. I was like, gosh, I could hear him talk forever. So I'm curious, though, as you develop the programs you're developing, how have things changed in the last 10 years? I feel like things have changed so drastically, but is that the social media hype of everything's changed, or is that a scientific fact? Have things changed, especially for children, over the last 10 years when it comes to mental health and distress and some of the areas you're looking at?
Yeah, I think there's been some good and some bad. So let's start with the good. Uh, a positive is that fewer teenagers are getting pregnant. Bullying is down a little bit, but it's coming in different ways, but not maybe the way it was 10 or 20 years ago. That's good. Certain types of drug use are down. So that's also a positive.
Can I ask you a question on that, though? On the, fewer teens are getting pregnant. Mm-hmm. That one help me what you think the underlying reason for that is. What's the driver for that decreasing?
I think on that, there has been increased access to birth control. And then I think how do I say this? I don't want to use the word appreciation, but I will, of like what happens to get pregnant early, that now you have a kid that wants to hang out with you for a while, which is great later on in the right context. But when you're 15, maybe you want to think through. So I think some of that messaging has resulted in a positive outcome. I think with bullying, schools have appreciated that that's a problem. And so they've done things that they can do within settings, which is a good thing too. And also things like drugs and drunk driving, it's happening. It needs to happen less, but relative to maybe where it was 20 years ago, we've seen a shift.
Do you think the decrease in bullying has anything to do with that this next generation is more community focused than maybe some of the other generations?
I don't know. Because I think it's still happening. I think it just happens differently. And, vis-a-vis social media and often sort of, quick in relational snubs. For example, I'm going to, take a picture with my friends and send it out. And you're going to see that you weren't part of our friend group as just one example.
Got it.
So different, but there.
And is there some, Jenn, that's an interesting question. And I often wonder too, does this generation of children have a broader sense of community and the sort of us versus them is not as strong as maybe when you and I were younger. But then on the flip side, as we've talked to some of these young kids, especially like late middle school, like freshman year of high school, there's a strong sense of desensitization that they don't even register bullying anymore, even though it's, I think, impacting them and affecting them. And you probably see it when you sit with somebody who has anxiety or depression. But they sort of toss it off to, oh gosh, we don't really care about that anymore. But I mean, I think they do. And I think it happens.
Mm-hmm. Mm-hmm. Yeah, absolutely. It absolutely does. I do think, though, one of the aspects we're thinking, sort of going to the less positive side, there are higher rates of suicide. I think mental health problems have increased. It's not just that people are willing to talk about it more, which is a positive. I think they have increased. I think the stressors are real. They're significant. The pandemic, which I'm not a big blame it on the pandemic guy, but I think it did sort of, take people who are at risk and, squirted a little bit of lighter fluid on that fire and made anxiety or depression a little bit worse for some. And I do worry about the kind of social media use, and not that it's a bad thing to use it sometimes, but just that we're seeing a lot of kids really get stuck in this kind of world where everything revolves around it, and it functions sort of as an addiction. So those are, I think, a few of the risk factors that really are coming into play.
No, and it turns out into one of the questions, Rania, that we had is, so obviously the pandemic kicked us into some virtual collaboration and communication tools, which in some ways obviously was very good, but obviously some cases harmful too. But do you find that in my world, the survivors we got more survivors to go to mental health treatment more because they didn't have to travel in to somewhere, or maybe they didn't have a car. Is that form of treatment, virtual treatment, still a very valid way of doing things? And are y'all finding it successful for in-person treatment, or is in-person treatment still better?
Yeah, terrific question. I think the question is sort of which treatment for whom. Telehealth has dramatically improved access, which is an incredible thing. And you pointed out a terrific example of that. At the same time, sometimes that type of intervention isn't quite the same in terms of the fit and quality. And sometimes it's even better. So one of the therapies I do a lot of is where we have people who are really afraid of things, whether it's obsessive compulsive disorder or an anxiety disorder. So the best treatment that we have is where you have them face their fears and don't escape from it. Now, sometimes that's good because the fear might be in the home. And so you're right there, easy. On the other hand, sometimes you just need to be there in person. And that gives a little bit more kind of interpersonal currency to get people to face a fear. Kids, especially young kids, telehealth doesn't work as well. But for, young people like us, like young adults, obviously, it's perfect. We can fit it into our schedules. We're engaged, not distracted. And so those, again, that can really make it a great option, as well as reducing stigma, reducing burden, all those things, Jennifer, you hit on that could be barriers to many people, time off work, stuff like that.
The silver lining of the pandemic, I think, is the increase in virtual everything. And what I really appreciated about your program is we sadly can be in many parts of the city or the county where parents can't take time off. They maybe even come from a background where they don't believe in mental health treatment. And that sounds strange, but there are really some cultures who can toss a lot of things to, that's all in your head, get over it, stop complaining.
And bear it. Yeah.
Yeah. I mean, there's a lot of cultures that still have that mentality. So the tool that you have of allowing kids to have access to virtual technology, is massive. How do the parents play a role? How does somebody tap into this if they're looking for it?
Yeah. In that saying, it takes a village to raise a child. Really believe that in all the work we do. So the other thing I believe, my uncle had said this to me in describing his role as a father. And it's something I've really embraced in my own life, professionally and personally, which is, you have a kid and you want that child to know that there's two people in the world who will do anything that they can to support them. And, sometimes it's one person, sometimes it's three people, whatever. But that's sort of our role. So as a clinician, we want to embrace the family. We want to teach them basically to be the therapist that works 24/7 at home, because we can't do that. And so we're really working with the parent to understand what they can do to support the child. And sometimes that's a really, really active role. Sometimes we've even taught the parent to be the therapist without even having the kid involved, because it works better that way. The kid doesn't even have to deal with this. We can target aspects of the child's anxiety, for example, by shifting the parent's behavior to help make them better.
So when you say that, what you do is your program, part of it is shifting therapeutic skills or talents to the parents so that they can handle it while they're at home?
I like that word, talents, too. Yeah, that's exactly it. So the first thing is, when you have a kiddo in play,
because I may need this soon.
Yeah, right. Hey, we sign you up. But we try to understand what the problems are that are going on. And then from there, you have different types of interventions that have been shown to work for that problem. Now, in anxiety, as I said, one of the biggest things is learning how to face fears. But one of the other things that we can do is teach parents how to encourage their child to face those fears. So it's a different way of delivering the same intervention, but that we've shown actually works well. And so we want to make sure we have multiple tools on our belt to really be able to help kids, depending on what problem they have or how engaged they are, what supports or things that are sort of challenges in their way. And so that's one of them.
Now, so do you find that in essence, you're also providing probably therapeutic support to that, tools to that parent for themselves, right? Because I'm sure they have my husband and I call it the backpack, right? You just kind of have your backpack of that you grew up with, or your environmental or family or cultural, and you carry that along with you. And my husband and I always say, like, you get this set of tools your parents give you, and then maybe you refine those tools a little bit or grab some tools along the way. And so what you're saying is you're arming parents with different tools they may not have had access to or been exposed to before. And then they're kind of becoming a therapist, but those tools probably help them too. So you're kind of getting 2 for 1, right? Wow.
I love it. And I love the backpack frame too. I think that's a clinical term, the backpack of, but it's like, no, right. I mean, that's exactly it. You're trying to think of what's kind of maintaining the anxiety, or the level or where you want to intervene. And then you're empowering everyone on that. And sometimes it's more the parent, sometimes it's, more the kid.
I'm going to have to tell my mother that I was born at the wrong time, because she should have gone to your talent program to make me better human. But wow, that's amazing. I've never heard, Rania, have you ever heard of that concept?
Not until we saw what they were doing. And it's so important because, again, we think we're seeing just this massive increase in need. Mm-hmm. And in our observation, you have children who have this need, but when you go back and look at the communities that they come from, it's clear that the families in the community have this need as well. So the fact that you're training the parents and giving them the tools to help the children is unbelievable. You start by talking about social media, and we touched on it a little bit before we got on the podcast, but kids today are absorbing so much. They are just constantly absorbing content online. There's many studies to show that the amount of time they're spending online is adding to, whether it's insecurity, depression, anxiety, fatigue, unrealistic expectations, a bunch of things. But then the content is becoming very graphic, and it can be very hard to swallow. We've been asked a lot recently about the images coming out of, the Israel-Palestinian conflict. A lot of young kids are consuming it. A lot of young kids are looking at videos of honestly dead children. How is this impacting this generation?
Mm-hmm. I really worry about this. I'm glad you brought it up. I think there are a whole bunch of potential negative impacts. One is it just engenders fear. What's the status of the world? Seeing things that are, disastrous happening, and an appreciation that these are people and this can happen to you. And again, if someone has a little bit of anxiety, this sort of just plants a seed or waters that seed. I think a second thing is sort of a desensitization to the atrocities, the horrors of war, and that you're seeing it, but it's still a bit removed. And so for some, it just becomes common. Like, we can see this stuff and not have the reaction that honestly we need to have, which is, this is horrible. People are dying, and the world isn't, the world needs a little bit of kind of tender, loving care to hopefully get people to start treating each other the way that they need to. So that's another concern that I have. I think there's a sort of a vicarious traumatization, especially for those that have experienced this or seen, whether it's war, whether it's other kind of traumatic events, that these become triggering points. And so these are just a few of the concerns that I have. And it's not just this conflict in the Middle East or the conflict in Ukraine, but throughout the world, that social media is displaying things that, as parents, we want to keep our kids away from as long as we can. But now they're being really exposed to it at earlier ages and with a level of intensity that I don't think makes any of us feel comfortable.
And this one is so much more complex. I've been calling it root cause confusion. Right. Usually in these types of situations where we've had a school shooting or a war, there's a bad guy and there's kind of, a victim. There's the bad guy and the good guys. Usually this one has such root cause confusion that there are like good guys, and then there's this bad guy that is associated that you think with these good guys. So it's just so complex for them to get their head. When we're talking about Russia and Ukraine, you can look at who the bad guy is, right? But in this one, there's good guys, and then there's, it's such root cause confusion. That's the level of complexity for a young child at that age. It's got to be exponentially more stressful when they don't know who the good guy and the bad guy are. Right?
Very well said. Very well said.
Thank you to our sponsor, FlipLock, for making this episode possible. FlipLock is a door lock unlike any other lock that was created as a nationwide, straightforward solution to protect your people, whether that be in universities, dorms, daycares, hospitals, or even government buildings. It can be added to nearly any door to keep you and yours safe. We are proud to have such a strong and like-minded sponsor of the Balanced Voice podcast. Check out FlipLock at fliplock.com. That's FLIPLOK.com.
Dr. Storch, question for you in terms of one, I have a personal question. One, are you born with anxiety? Like, are you born with your brain wired to have the propensity for anxiety or depression? Or do effects of life, I mean, could you be totally fine and just things after things happen and you develop like clinical depression or anxiety?
Mm-hmm. Yeah. So one of the areas I work in, it is genetics, in this case in OCD. And so I have this wonderful project with equally wonderful colleagues around the world where we're studying genetics of OCD among individuals who are Latin American. And we've taken that platform to not just study that aspect, but to really build out training opportunities throughout all of Latin America. And so I'm finally in my pathway to figure out how to retire in another country, and finally learn how to dance the tango, which right now I think my wife could say I'm helpless, but it is hopeless but improving. So I think it's a combination of both of those things. When you think of genetic contribution to something like anxiety or OCD or depression, there's absolutely a link there. But one of the ways that we might think about it is it's sort of like this kind of risk that comes into play. And genetics suggests to what degree you might have an increased risk of developing this. It's not at all predetermined. But again, people have different levels of risk, and some of that's passed down from your parents and then your grandparents to your parents and so on. But I think those environmental aspects can come in, and depending on that risk, it sort of gives you an idea of how sticky those environmental things are going to be. So you could have have pretty high risk for depression and some adverse life events, and you're just more likely to get into that funk, and sometimes get out of that funk as well. Same thing with anxiety, or trauma or aspects like that.
I ask because, sorry, I was curious, Jenn, do students who want to come see you go through your program, do they have to have a diagnosis before they come to you?
The short answer is no. It's been interesting that in my work, 20 years ago, we would make a lot of first-time diagnoses, and now we actually don't. People come in and they say, I got OCD. They tell me some stuff. It's like, oh, you have OCD. And then we start with the treatment. So that's been a little bit of a shift, which, is what it is. Doesn't change what we do much. But no, I think, when people recognize that there's some sort of, concern that they're just not happy with, like they're nervous in social situations, they feel down the dumps, but they see their friends not being down the dumps. That's all it takes, just to reach out, whether it's here with our group, or with your pediatrician or your doc or someone else that just say, hey, I'm not, I'm feeling this way, or any thoughts or so on. And then a little bit of grit, meaning you might not get the right answer immediately, but you just have to keep, sort of pushing it. When it doesn't feel right, keep going after it.
So how does this work? So the points of entry into your program, like, for example, I've seen times where my boys have gone through stressful moments in different times in their lives. So I could have been like, hey, here's a phone number to Baylor and Dr. Storch, and you call whenever you need to, here's the information. Or is it that's one point of entry right through the parent. through a program like Crime Stoppers that gives this information out to the kids when we do our presentations. A third way could be through the school or any interaction through another institution. So there are multiple pipelines of which y'all would, when the kid calls, are you letting the parent know the kid's calling and saying, hey, because they're a minor, the adult is, I want to make sure the listeners understand that, if their child's being seen potentially by your program and maybe the parent didn't know, y'all are going to contact the parent. Is that correct?
Yeah. And actually in our particular immediate work, we have to have the parent sort of kind of leading that charge, which they can do together with the kid. One of the things we do is a lot of research. And so one of the nice parts of this is it allows us to hopefully affect change for other people down the road as we're helping the person at the current time. So really just, Jennifer, as you described it, it's, whether it's an email to, on one of those flyers that, it isn't one of the Crime Stoppers presentations, or a phone call to Baylor Psychiatry is another example. Those are all great ways of getting in touch. I spend my entire life, I will say, on either Zoom, occasionally with a Teams meeting, and then emailing. Those are pretty much the two things I do, and then throw in sleep, and you got my day. So I'm also always available to parents to just email me and say, hey, I'm worried about my kid. I always think about kind of my mom, and if she once told me this saying I love, which is, a worried, the FBI can't do better research than a worried parent. And so I always want to be able to respond to that worried parent and give them a direction one way or another, whether it's here, whether it's somewhere else, that they can try to find some support.
You also focus on, and I'm seeing more of this, especially in the space that I've moved into on the site: hair pulling disorders, skin picking, cutting, self-harming, like that. Has that always been here, Eric, or is it on the rise? It was just a different form of that we're seeing now that we didn't see before. I just don't remember those when I was a kid.
Mm-hmm.
Now I do remember kind of putting somebody's name, people putting names in their skin. I didn't realize that wasn't called cutting back then, but is this on a rise?
Yeah. Great questions again. So I think the hair pulling and skin picking, I would actually separate from the self-harm. And so those we consider body focused repetitive behaviors. I think those are probably similar in incidence now as, let's say, 20 years ago. We just didn't talk about them then. And partially we didn't talk about them because no one knew what to do with it. And so now we have some ideas for that. So people are talking about it more research too, all that good stuff. I think self-harm has increased. I think it was always there, as you described. I think we are calling things that maybe kids just did now self-harm, to your point. But I do think there is a little bit of a increase. And so it's become a tool, which I have my air quotes up, for which people to cope, but that, it's sort of passed on. Wow, you're distressed. Here's one thing you can do. Whether it's directly through social media, through talking about it, whatever. So I do think that part has increased relative to 10, 20 years ago.
Is it an either or, self-harming versus smoking weed? Like, because rather than self-harming to kind of numb out or take pain or a focus of a pain, people just smoked a joint. So is there an either or? Are you saying, I'm not talking about myself, Mom. But is there an either or? Maybe I am talking about myself. Sorry. Does that make sense? Or do you see them in tandem sometimes?
Yeah, you definitely see them in tandem quite often. And sometimes you think of all these ways as sort of ways of dealing with distress, just kind of maladaptive ways. I think a problematic way begets another problematic way, and so you often see them co-occur.
Okay. Wow.
There's so many different issues kids face today and families are facing. For those listening who are just curious or downright struggling, what do you recommend that what do you do? Is it start with a phone call to you or to your, as you said, your physician, your family physician? Is it try these 3 things first? I mean,
yeah. So the negative, as you pointed out, there are a lot of challenges for kids currently, and it's hard to know, is this worse? Is this better than it was? As we sort of talked about. I think the bright side is that there are more resources out there. So let me describe one. There's the Texas legislature has been incredible about really dedicating funding to support child mental health, whether services directly in the school, or another example is where your pediatrician can actually phone a psychiatrist who's waiting for their call to give consultation, or a behavioral
almost
therapy.
Immediately, like while in an appointment. Oh, wow. And the Texas Ledge is supporting and funding some of that?
Very generously funding that to the 12 academic departments of psychiatry across the state. So Baylor College of Medicine being one of them, UT Houston another one, but really all of the academic institutions across Texas. So it's dramatically improved access to service. The beauty is that it's free of charge. So those sessions in the school cost nothing at this time. So
That's phenomenal.
That's a positive one.
Phenomenal.
Yeah. Phenomenal. And nobody really knows about that. I didn't know that.
Yeah,
wow.
There's been an incredible amount of work getting the word out there. But to our point, there's still more work to do it. And we're thrilled to really be a part of that endeavor. But I think one immediate piece is talk to your pediatrician. Here's what I'm seeing in my kiddo. Any thoughts? Second is get online. It's amazing how many good parent-guided books or teenage guided books are available, for $15 on Amazon. Third is, sort of be that worried parent doing better research than the FBI. And so just, reach out. And there are sometimes some resources that are out there. So one of the things we do here at Baylor is, while we try to do research, we try to make it accessible in the sense that people are able to get free treatment, whether it's for anxiety in their kid, whether it's for depression or for trauma. And so these have been different endeavors that we've really spent a lot of time working on and sort of, help us advance the field, but do so while we're helping kids out at the same time.
Do you have to qualify for these services, like financial need to qualify for free services at Baylor?
So in our, within our research studies, no, not at all. Within our different clinic, like broadly the clinic, they usually take virtually every type of insurance at play. Within my OCD program specifically, we've set it up so we actually can provide extremely low cost treatment, including potentially free treatment. So we've really wanted to take out every access barrier possible. So we can even do it by Zoom. So really it's, you got to live in Texas and you have to want to get help. So that is easy as you can make it.
On y'all's research, do y'all collaborate? We met with Rania and I met with not too long ago on the podcast Arnold Ventures. So do y'all share information with them or work on co-projects together as partners?
We haven't. We came really close on one project, but we haven't yet. But would love to.
They're amazing.
Mm-hmm. Yeah, very much so.
That's great.
Very much so.
Wow. I'm kind of proud to be a Texan right now. I'm really excited that Ledge is supporting y'all. How can the everyday individuals support you, or not only obviously using your clinic so that information can be shared with research and make that more mature, but how do we engage with you? What can we as an individual community leader do to help?
That's fine. I think of it almost the other way around. Like, how can I support the families? How can I support you all? I think just reach out. One of the challenges I think with behavioral health problems is that it feels really alone. And
yes.
I remember early in my career, I had this 30-minute commute, and it was a good commute. It was, from St. Petersburg, Florida into Tampa, where I live. And so I'd go over the bay and I'd be looking, but I used that 30 minutes to talk to every parent that called my clinic. And I would just talk to them. What else am I going to do? And so I had one mom once who responded to something I said, which was, I don't ever want you to feel alone. And so that resonated with me. I mean, to this day, that notion of it's a lonely journey, but just reaching out. There are people there to support you. And that's what I need parents to do, is just reach out. If you don't, it's impossible to help or guide or so on. Won't always have an answer, but we'll keep trying. So I think that's probably the biggest thing, is just reach out, be noisy, be squeaky, and we can try to get some oil to you.
I think too that the community, as we talk about village, I'm such a village compound kind of person, but it's also making it acceptable to be vulnerable as a family or an individual, that if your child is going through this, they're not going to get berated. They're not going to get shamed or, be made fun of, or in some sense that we as parents know that our children, no matter what, are going to go through some type of mental health obstacle as we grow up in the world that we're living in. So I think that's too a way that we can learn, maybe from your research, how to be better community leaders and support those families when we know we need support in our own family at some point.
Absolutely. And nothing wrong with asking for help. And what I'll often say back to families is, who are concerned about, stigma or whatever it means to reach out. I always kind of, just remind them, well, what happens if you don't reach out? Like, the side effects are worse of not doing this. My father-in-law has this saying, little kids, little problems, big kids, big problems. And I find that to be the case. Like, if you could address it when it's smaller, it's so much easier than when it becomes this massive thing. And too often we see that you get a kid who graduates high school, let's say, and they don't work for a couple of years. It's really hard to reintroduce them into the workforce or reintroduce them to school if they've been out of it for a while. So the sooner we can address things, the better off we are from an outcome standpoint.
Dr. Storch, you are doing incredible work. We're so proud to be partnering with you and Baylor College of Medicine, and we will be linking ways the community can get in touch with you and get in touch with what you're doing. The studies that you're doing are so important, and for people who are in need, try to tap in and take advantage of this. And the more you do so, I would assume the more Baylor's going to study issues and offer these services and be funded to do this type of work, which only gives back to all of us and our families. Mental health is a huge issue. Untreated mental health is a burden that too many people carry than they shouldn't. We thank you for the work you're doing and for your partnership with Crime Stoppers.
No, well, feeling is the same, and thank you all so much.
I'm gonna have to send my son, be like, George, son, when I'm driving you crazy and I'm here, please call Dr. School.
Yes.
Yeah, I have no life. Yeah, by all means.
Thank you, guys.
Dr. Storch.
So much. Thank you, Jen. Enjoy Florida. We'll see you all next time on the Balanced Voice podcast. Take care, everybody.
Thanks for tuning in to today's Balanced Conversation. You can find real solutions and tangible resources in our show notes at thebalancedvoicepodcast.com. To join the conversation, follow us on Instagram at The Balanced Voice Podcast and on Twitter at @BalancedVoice_. Stay up to date on Rania's work by following her at The Rania Report, and we can't wait to see you next week for another Balanced Conversation.